Okay, I'll go ahead and get started, and then if people just come on while we're doing this, that's fine. So those of you who don't know me, I'm Nora Kolnatsky. I'm the wound and ostomy nurse here at the hospital, and work full-time on the inpatient floor, taking care of people with wounds and new ostomies. And just recently, this past spring, started also working kind of per diem in this blueprint position where um, I've been set up to start seeing people in the primary care setting as long as they kind of qualify for the primary care offices that we're using, which is like mostly the Notch offices, St. Albans Primary Care, to help just assist with wound care needs in the outpatient world. And so that's what this kind of lunch and learn educational session um, is being brought to you through. And the hope is really just to provide tidbits of educational information for nurses working in the community, whether that be through primary care or other avenues. I don't think we're going to have much attendance through the home health world, but certainly that would be appropriate too. And so these kind of like lunch and learn sessions are just meant to kind of provide you all with information that you are looking for. So we were advised that this topic was of interest. I think mostly because we've had a kind of a lack or some gaps in being able to provide care to these folks in the outpatient world, just because we had Dr. Groening retire back in March, and we did not fill his position with a new podiatrist. So our ability to treat people in the NMC orthopedic office setting is limited because we just don't have the capability to reach everyone who needs that service. So if they're being seen in primary care, um, the hope is that we can kind of try to help these folks the best we can. Um, so this is going to be just keeping it really simple and basic. Again, we only have an hour, and the hope is that, there's time for questions or, conversation at the end if anyone has anything that they want to bring up. So we really can only scratch the surface. There's a lot of information out there, and we're going to just try to keep it simple. Um, so this thing keeps getting in the way. So this was kind of sent out when we like advertised that we were doing this, but just to reiterate, the purpose of this presentation is to um, just, understand that foot ulcers are a very common problem in the community. They have a huge negative impact on quality of life. And so anything we can do to help people who are at risk for foot ulcers to prevent them from developing is helpful. And then anything we can do to help kind of manage the ulcers once they already have them is helpful. And so this presentation is appropriate for any nurse or, MA or whoever is working with this population. Again, so we're going to just talk about how to help folks who are at risk. We're going to help give some tools on how to manage these wounds, especially if they are having trouble getting seen by a podiatrist, and we just have to kind of use what we've got. Basic understanding on how lower extremity neuropathic disease and diabetes can lead to foot ulcers, and then understanding how your vascular assessment is going to be important when you're looking at wound healing in these people. So just a little background, LEND, lower extremity neuropathic disease, or peripheral neuropathy, all of these are kind of like interchangeable. But basically, peripheral neuropathy is when there's damage to the nerves in the lower extremities. There's different kinds of neuropathy, varying degrees of the severity of the neuropathy, and the way it presents can be different, whether it's like complete numbness versus some pain or a little bit of both. The most common disease that causes peripheral neuropathy is diabetes. There are others that cause it too. It's not just diabetes. So you can see foot ulcers, and other symptoms that go along with neuropathic or peripheral neuropathy, and they may not have diabetes, but certainly diabetes is the most common. And um, so neuropathy is one of the most common causes of foot ulcer development. And then kind of like to break that down a little bit more, is, when someone has a callus formation, it can start there, or it can start with traumatic injury to the foot. If they step on something and they're not aware of it, or they're wearing shoes that are too tight or are rubbing in the wrong spot, or there's moisture buildup on the skin on the foot. These are all things that can kind of lead to ulcer development. Um, And so the pain that's associated with this nerve pain, like I said, there's different ways this can present itself. So they might just be completely numb and have zero feeling. And then there's different ways that numbness can present itself. It might just be certain parts of the foot, not the whole foot. And then they might have some kind of intermittent pain. The pain can look like a pins and needles type feeling, sharp burning, can include the lower leg as well. Sometimes it's worse at night. So, the majority of these folks are likely to have diabetes. We know that the prevalence of diabetes is quite high, and it's growing. And so it's a high volume of the folks that we're seeing. And it's just good to have that awareness. The rate of lower extremity amputations is 28 times greater for people who have diabetes compared to those who don't. So it just is a long road. Even if they have an ulcer that goes on to heal, they're at risk of it coming back or developing new ones or just more problems. It's an ongoing battle. So whenever we can, certainly we want to try to prevent. So a lot of that has to do with patient education. Certainly, we have plenty of folks who are just non-compliant or non-adherent to what the recommended action is, and that's their choice. But the best thing we can do is continue to provide them with that important information. And so a lot of that looks like this. So best practices for these folks. So if they say they are diabetic and their feet look beautiful. So these are the things that I tell them. Ideally, certainly I understand that right now this is challenging, but ideally they would be established with a podiatrist and they would just schedule annual foot checks. That's part of the basic preventative care. Sometimes that frequency can increase up to Q6 months, but just kind of like you have an annual, it's recommended you have an annual, certainly physical with your primary care provider, annual assessment from like a dermatologist to have your skin checked. If you're diabetic, having an annual visit with a podiatrist is best practice. And so, in addition to that, what people can do on their own at home, which is really important, is daily foot checks. We're not always looking at the bottoms of our feet as we go through the course of the day or multiple days. So sometimes things develop on the bottoms of our feet and we have no idea. And if you're not looking, or if you do have some kind of neuropathy and you can't feel anything down there, it's important that you actually set aside time to look at your foot and look at the bottom of your foot and look for anything new that's developed. Whether that be, any kind of redness or callus formation, macerated tissue, just anything new or different on the skin. And then also including checking in between your toes when you do a foot check. Because if there is moisture buildup in between the toes, that can lead to macerated skin. And then when the skin gets macerated, it's soft and prone to breaking down. Again, especially in people who have diabetes and neuropathy. And so proper footwear is so important. Really can't stress that enough. If someone is wearing shoes that don't fit well, if they're too tight, or if they're rubbing, in one area, there's not enough width to the toe box to accommodate whatever's going on in the toes, especially if those toes have like any kind of deformity or nail issues or like hammer toe type situation, bunions, all of that. You need to make sure that the shoe is wide enough to support all of those structure changes in the foot, because if it's not, it's going to be too tight and rub, and that's how ulcers start. And then definitely to avoid going barefoot. Um, even at home, inside the comfort of your own home, just because if you have that neuropathy, you can't feel the bottom of your feet, that's where it's so easy to get damage, to kind of get started. You're walking around barefoot and you're not aware of what you're stepping on. There's a lot of mixed information, I think, out there around soaking feet, to soak or not to soak. Um, I always recommend that people with diabetes do not soak their feet. And that is simply because when you do that, you're immersing your foot and toes into water and just having it sit. You're really prone to macerating that skin and softening that skin potentially too much to the point where it can break down. The the thinking with soaking is that it can soften thick callus tissue and make it easier to kind of like clean that off. And that is true. And if it's being done, by a professional like a podiatrist, there that can be effective. But otherwise, for people to just be on their own at home soaking their feet, it can cause more harm than good. So I recommend they stay away from that. And then if they have a lot of issues with their toenails, if they're just really thick and difficult to trim, that's something that is totally appropriate to have done in the podiatry setting. Someone who's trained to do that. And so those are really some of the best practices that we can encourage people who are at risk to do. And then, of course, there's all of the risk factors that are modifiable that we know can have a direct impact on diabetes and overall health, including risk for ulcer development on the feet. So that includes exercise, weight loss, smoking cessation, having your blood glucose levels be in tight control, and then just continuing to practice all the preventative care that's listed above. So that's really it for the prevention piece. I'm just going to keep trucking. If anyone has any questions, don't hesitate to ask. Otherwise, we can do more at the end. These are just some visuals. These ulcers can take all different kinds of effects in terms of the way they present and where they present on the foot. Sometimes they might not actually start out as like related to a diabetic etiology. So like, for instance, if they happen to be diabetic and they are hospitalized and they have poor mobility and their heels are pressing up against the mattress, they can develop a pressure injury on their heel. And so the initial injury to the skin is actually caused by pressure. And that's what you see up in this top right-hand corner, is a skin injury that started as pressure, but then, this is in someone who's also got not well controlled diabetes. And so it kind of just turns into this complex physiologic process where it's like it started as pressure, but now we've got this neuropathic component to it. And there's all different things that you have to kind of consider when you're looking at treating something like that. It's not your just straightforward open wound. What do I put on it? Um, Whereas these in the center kind of are. And this one on the bottom is a good one because it's very common to see these edges around the wound are macerated. And so you get that when the wound is doing a lot of draining, and that drainage is touching the healthy skin around the wounds, the edges and the skin surrounding the edges. And so it can really cause a lot of harm when the skin gets macerated in that way, because if it's not cared for properly, it just makes the wound bigger, because then all of those macerated edges can break down and open up, and the wound gets bigger instead of smaller. Okay, so now we're just going to get into, what some basics on what do we do about it. So the first thing that is really like the most appropriate thing to determine is there even enough blood flow to the feet to realistically heal what's going on? Because if there's not, I mean, it really doesn't matter what you put on the wound, you're going to be left with this chronic, stalled out, non-healing ulcer. So ways that you can kind of like gauge blood flow to the feet include, touching the skin and the foot for the temperature, looking for capillary refill time, uh, trying to palpate pulses. Sometimes that can be tricky if there's a lot of swelling. So you can use a Doppler to help get the pulses. And if you're able to get an ABI or a TBI, that's going to be really helpful information. The only thing is when someone is diabetic, often a TBI is going to be more accurate than an ABI, just because the ankle brachial index in people with diabetes can be, you can get falsely elevated levels. So it looks like their blood flow, if you're looking at the scale and the number that you get, looks like their blood flow is better than it actually might be. So it might not be a reliable number. So it's usually recommended to go with a TBI, or just go straight to the vascular um, specialty, and they'll do the full testing with the whole series of blood flow testing. And that's really going to be the most accurate way to identify what their blood flow is like. Other little things you can look for is if there's hair growth on the legs. Sometimes lack of blood flow can result in like shiny skin that doesn't have much hair growing. Certainly just need to make sure that they didn't just shave their legs, and that's because that's obviously different. And take into account whether they smoke or have used nicotine, and then are they followed by vascular already, and have they already had some work done? So these are all things that are important to include when you're trying to form a treatment plan for someone with a foot ulcer. And so then the next piece is certainly, are they a diabetic? If they are, is their diabetes well controlled? Because it's going to have a huge impact on wound healing. So you want to take into account their A1C level. If they haven't had one done in a while, that'd be good to get. And work on making sure that, their blood glucose levels are tightly controlled. And sometimes there's barriers to that. And so then it's just a matter of trying to identify what the barriers are and work with the patient to try to meet their needs. And so certainly, as we talk about barriers, it's quite obvious that this is a team approach. Not one person could be expected to just heal someone's foot ulcer. There's so many needs involved in this kind of care. So obviously a podiatrist is the specialist who is ideally involved, but then, anytime you can get a vascular assessment, is best. And then we need to include the care management approach, nutrition, physical therapy, primary care, orthotists, infectious disease, wound care, endocrinology, all of these things to really meet all their needs and realistically help them go on to heal. Um, so when you're looking at a wound, you're assessing the wound itself. These are just some basic, common tissue types that you're going to see. Um, Obviously, the tissue we want to see is healthy red granulation tissue. That's ideal. Anything kind of yellow and fluffy looking is dead and non-viable. Any kind of black tissue is necrotic. The tissue might be dried out and crusted, or it could be moist and draining. If the wound bed is pink, um, it's like not your healthy beefy red, and it's just kind of like a pink color that kind of indicates that it's stalled out, just kind of in a chronic state. And then, so obviously you're looking for if there's any need for debridement of any of that non-viable tissue, and then is it infected, of course, which is important to know. So technically the Wagner scale is what's used to grade foot ulcers, diabetic foot ulcers. I don't use that. I think it's done at the provider level. But basically the grades go from 0 to 5, and 0 is like a healthy foot with no lesion. And then 5 is like your entire foot is gangrenous. And so then all the numbers are kind of like the levels in between. So again, when you're assessing the ulcer, not only do you want to look at the wound bed itself, but you want to look at all the other characteristics. So like that last picture I showed you with the macerated skin edges, you're going to look at the skin around the wound and look at the edges of the wound and take that into account, because that's just as important as the wound bed itself. So are the edges macerated? Is there redness in the surrounding skin? Is there a lot of swelling? Is it indurated? There's any kind of like pockets of fluid happening? Is it purple and discolored? So there's all different kinds of things that you can see. And then, drainage is another big one. Is it draining or is it dry? If it's draining, what does that drainage look like? How much of it is there? That's all going to drive what you put on the wound. And then where on the foot is it located? Because you're going to do different things based off of where on the foot it is. So when you have an ulcer on the plantar aspect of the foot, it's going to be really tricky, because technically it's probably not going to heal if you're bearing weight on that ulcer. And so you're going to need to try to come up with a plan to get that weight off of the ulcer. And there's different ways to do that, and we'll get into that, but that's going to be a key part of the treatment plan. The gold standard for these types of foot wounds is an MRI. That is the number one way you're going to rule out or rule in osteomyelitis. We don't always do an MRI right off the bat. We often start with an X-ray, and that's fine. Sometimes X-rays can pick up possible osteo, but I've definitely also seen patients with X-rays that were not correct, and they actually did end up having osteo on an MRI that was done after. And so really an MRI is what's going to give you that information. Pain, just like with any kind of wound care, you want to take pain into account. If someone does have like severe neuropathy, a lot of times you're working with these people and you're like packing a lot of material into a deep wound and they can't feel a thing because it's totally numb. But certainly you want to take pain into account and include that into your plan of care, because if it is painful, they're going to need to be pre-medicated. And then, size in terms of severity. Obviously, if it is severe enough to where like tendon, muscle, or bone are exposed, that's when you're certainly going to want to include a podiatrist. They may or may not need to be taken to the OR, but you're going to need specialty care in terms of how we're going to go about healing this. And then, it is appropriate to kind of like, if you're a provider seeing this wound and trying to assess it, um, to explore the wound, get a sterile Q-tip and find out what's going on in the tissue. Is there any undermining, meaning space under the skin edges that you can get that Q-tip into? Or are there any tunnels, like areas that are deeper pockets compared to other areas in the wound? And then edges. You always want to take edges into account. We already talked about maceration, but epibole is another big one, which is where the edges kind of roll over. And if the epibole is severe enough, that they're so rolled over, you're going to need that to actually get sharply debrided, because the skin will not be able to connect, like grow back together if the edges are rolled. Okay, so this is kind of just like real basic guideline on what do you put on the wound, or like where do I even start? So you start with, is the wound dry and intact or not? This real, like, the basic first thing you're going to ask, because a lot of times if the wound is on a heel or anywhere on a foot really, and if it's completely dry, and when I say stable, I mean zero signs of infection. You touch that dry tissue, it's not soft and mushy. Um, there's no drainage or pus or any kind of like pocket of fluid that's like exposing um exudate, when you push on it. It's dry, it's intact, there's no redness, there's no swelling, there's no odor, there's no signs of gangrene, like um no real concern for infection. It's just there, dry, stable, and intact. And if you don't know what their blood flow is like, if you don't know how well their arterial flow is, then you're better off to just leave it dry, stable, and intact. And try to get them in to be seen by a podiatrist for further evaluation. But there's no need to go softening up that tissue or debriding that tissue or creating an open wound in someone's foot if we don't actually know if they have enough blood flow to heal it. Um, and that is the um, definite recommendation when it's on a heel, because it tends to be even harder on a heel. And so what we do in those instances is we get betadine swabs and we just paint right over all that dry, thick tissue, and then kind of like all the surrounding skin, and really just get it all nice and orange. And what it does is it just helps promote it to stay dried out. And it helps, provide a bit of a microbial effect to the tissue. And generally doing that twice a day is good. Sometimes if the betadine is taking a while to dry and you don't want it to get all messy, you can just put like a dry dressing over it. Doesn't really matter what you use, like gauze or ABD pad, Curlix wrap, anything like that, to kind of just, um, I guess, protect it a little bit more. The one thing that is important to recognize in these dry, stable wound beds is these are the folks, and this can be confusing on the inpatient floor. And so I tell the nurses that we actually do not want to put the Mepilex heel dressings on a heel with this type of wound, because what those bordered multi-layer silicone foam dressings do is they're moisture retentive, and they can kind of trap moisture. And so you may have a dry, stable, intact wound on a heel, and then you put a Mepilex on it, and overnight it softens and kind of gets moist, and then it's not dry, stable, and intact. And then you're looking at definitely needing to debride it. So just be aware of that. And then if you have a wound that, is certainly not dry, stable, and intact, and you have to do something with it, more often than not, there's going to be some kind of non-viable tissue in the wound bed that needs to be debrided. It's not really very common that someone's coming in with healthy red granulation tissue in their foot ulcer. So Debriding is definitely ideal. There's different ways to do that. And I have another slide that will kind of dive into that in more detail. But cleaning and debriding is step one. And as I said before, if you have rolled edges, if they're severe, you're really going to have to debride those too. And then in terms of what to put on it, you do your basic cleaning, but don't um, overlook that step. You're cleaning the wound bed and the surrounding skin is like key important step. And then another important step is treating the skin around the wound. So the point is to prevent that skin around the wound from getting macerated like what was in that photo. So that's best done with some kind of barrier product. We like to use the liquid film barrier products. And so that's like your Skin Prep or your Cavalon or anything that falls under that umbrella of liquid film barriers. And a lot of companies that carry wound care products are now creating a version of that. So that's what's going to kind of really block out the drainage from seeping into the surrounding skin. And then if your wound is draining, you need to put something dry on it that can absorb the drainage and can be cut to kind of fit the wound and fill the wound right over the open tissue. So any kind of alginate foam, hydrofiber. If there's any concern for infection, you would want to incorporate the silver version of those. So it would have the AG listed on the wrapper. And then you're still going to need to cover it with something else. So whether that be sometimes a bordered silicone dressing like a Meplex is appropriate, but generally on the feet, I tend to stay away from those and cover with something else, maybe a non-bordered foam or ABD pad or gauze, and then you can like wrap with gauze to secure it. But something to kind of cover that first dressing and hold it in place. And then just a reminder that again, when you're working with these folks, there's so much more that is equally important than just what you're putting on the wound. So MRI results, A1C, any other lab work, culture if needed, what they're wearing on their feet, what their nutritional status is like. All those things are just as important as what you're putting on the ulcer. So just to dive a little bit deeper into debridement, so obviously sharp debridement is pretty straightforward. It's someone who is generally at the provider level and has that training to do, whether it be bedside sharp debridement, which often can be done in the outpatient setting, in the podiatry setting, or if it's severe enough to need to go to the OR and have that type of sharp debridement. But even after that, especially in these foot wounds, it's so common where the non-viable tissue just builds right back up, like within 24 hours after a sharp debridement. It happens so quickly. And so it's an area of the body that it just often regularly needs debridement, like with every dressing change. And so it's important to just be aware that there's other options. If sharp is not realistic, if you're not able to get them seen by someone who can do that, there are other ways to have debridement take place. There's dressings that promote this like autolytic debridement process to kind of where the body does it itself with the topical dressing. So like some people may have seen that I've started using this Ergo Clean product that has debridement properties. It's called integral debridement. Hydrophora Blue sometimes can have debriding properties. So there's topical things you can put on, enzymatic like collagenase ointment is a good debridement product. The problem with that is it has to be applied every day. So you just have to take into account like what this patient's picture looks like, what's realistic. Is a daily dressing change realistic or not? how active are they? Are they working and on their feet all day? So there's just a lot of different things that you need to take into account when you're making a plan for wound care. And then mechanical debridement when you're just simply cleaning can be quite effective too. They make these Deborah Soft pads, which can be used with a wound cleanser to just kind of gently scrub the wound and get some of that debris off and clean it as best as you can. Okay, so just another couple points on the dressing selection. I already mentioned that you might want to consider silver dressings if there's any need for antimicrobial effects, and then any kind of space or depth within the wound does need to be filled. So if there is a tunnel or if there's undermining, that space does need to be filled with dressing material. You can't just cover the wound and call it a day. You need to pack into that tissue. And so it's important to have products that are meant for that. And then also you have the right amount of product, because you don't want to be putting multiple pieces into dead space into a wound bed and then be in a position where you're trying to fish them out later with the next dressing change. You want it to be really easy, just one long piece of dressing material to guide into the open space in the wound bed using a Q-tip. So there's only one piece to take out at the next dressing change, and really leave that tail hanging so it's easy to remove. And then, any other products that you're going to put on the wound is going to be driven by drainage is a big one. So how much drainage is there? If there's a lot of drainage, then you're either going to need a lot of layers of good absorptive products to really manage that drainage without totally macerating the rest of the foot. Or a lot of times the most effective form of care can be a wound vac, negative pressure wound therapy. We use those quite a bit, and they're often really effective. Um, and just to reiterate, consider using dressings that have debridement properties, and then to always protect that peri-wound skin and the edges. So, other parts of treatment include not just the dressing, but then taking into account compression. More and more, I feel like we're using compression in conjunction with whatever topical therapy we're doing. Even if we're doing a wound vac, we'll put it. Sometimes it's just a light compression, but anything that's going to really keep that swelling down is going to be effective in promoting wound healing. Obviously before you compress someone, you want to make sure that they do have adequate blood flow. So it's appropriate to get that information first, but you can do light compression on people who have minor, arterial insufficiency and still be safe to compress. So I think that it's coming out that it's worth it, and it makes a difference. So that's when you apply from the base of the toes up to 1 to 2 inches below the knee, to just compress the whole limb and keep the swelling down. And then you really just can't stress enough how important proper footwear is. Again, just like other concepts to this. It doesn't matter what you put on the wound. If you're not wearing proper footwear, it's not going to heal. So you have to have footwear that's sturdy, that is wide enough, that fits the whole foot well, leaves enough space around the toe box, space around bunions, deformed toes, all of that. Footwear that's not wet. Sometimes people who, if they are homeless or spending a great deal of time outside and they're in the rain and their feet get wet, or like in the snow in the wintertime, these are all things that can really have a negative impact on the foot, and can cause problems. So total contact cast is what's applied to a foot when someone has an ulcer on the bottom of their foot, on the plantar aspect, because especially if this person is ambulatory and up walking around doing things, or even, needing to go to work every day, they need to be able to carry on living their lives and walking. But if they're bearing weight over that ulcer on their foot, it is not going to heal. So this contact cast allows for the foot to be wrapped in a way where the pressure is being offloaded from the ulcer, and the weight when they bear down is on kind of the rest of the foot in the cast, and the ulcer itself is offloaded. So that's something that needs to get applied, in the orthopedic podiatry setting by someone who's trained. But it is really quite effective for getting the weight off the ulcer. And then again, just stressing the importance of using the team. And that is it. That's all I got. I don't know how we're doing for time.
12:42.
Okay.
Typing in the chat. See if anybody has questions.
If anyone has
Sure.
any questions or comments or anything, feel free to just.
Oh, Susan raised her hand. I don't know. If we turn up the volume here. Let me see if that works. Could you try speaking, Susan? Oh, she's muted herself. You're muted. Susan, you can ask your question.
Hi.
Hi.
I couldn't figure out how to unmute and it wasn't letting me type, and then I was starting to panic. I wanted to ask, as far as you and I have worked together before, Nora, you've helped me with a patient, and I really appreciate that. As far as getting these supplies and things better in primary care, is there a thought on better I don't want to say better collaboration, but maybe more just working together? Do you know what I'm saying? Like, I don't think I said that right, but
For getting supplies.
yeah, and just having kind of your expertise available too. And is your PowerPoint printable?
Oh, are you able to? Sorry, we're having volume issues. Yeah, we can send the PowerPoint along in an email. I think this is also being recorded, so it should be available on our NMC Gateway.
Yeah,
I
on the
guess,
YouTube
the
page.
YouTube page, so it's
Mhm.
something that can be accessed again after today. And then as it pertains to supplies, so it's a great question. So in terms of, my availability and my services, being embedded in St. Albans Notch, St. Albans Primary Care, I am available. So if you have people in your practice who you want seen, generally what we've been doing is having the nurse care managers reach out to me, because they all have been introduced and they know how to reach me. And just let me know that there's a patient in the practice that the provider wants me to see, and then we kind of go from there. We coordinate a day and a time to bring them in, and I'll go over. And then sometimes it's a situation where I will continue to follow that patient, or kind of give guidance and direction on, on what else can be done for them, and be available as needed. And so generally when I see people, I always have supplies with me. I do have a um, whole um, formulary of supplies that I'm using specifically in this blueprint role for the community setting. So I do have access to supplies to bring to patients when I see them, or to leave with the nurse care managers over there if they're going to continue to have wound care done in the office, but maybe not by me, so that I can supply stuff. Or if we're looking at just getting the ball rolling and then having home health come in and do the rest. Home health can continue to help them get supplies. And then another route that we have started using recently, which is still kind of new, but there are companies that we're able to access that basically carry all your basic wound care supplies that are more specialty than like gauze, and can be ordered and sent directly to the patient's home, and they bill the patient's insurance. And so that's also a sort of smooth once we get it up and running way to get supplies delivered to the patient so that they have it. Because sometimes we're also relying on the patient or family members to do dressing changes in the home, kind of in between. So those are all kind of ways to get the supplies to the patient.
That's super. Thank you. I didn't realize that. And then just one more question. As far as, I think I've gotten messages that says our podiatry team is not seeing patients for diabetic foot care right now unless there's an active ulcer. Is that correct? Okay. And
I think
so
so.
what other um what other options are there? Because, I think some of the home health nurses used to do that, but maybe that's not a covered skill anymore either. So just didn't know what the best follow-up to that would be.
Do you want to move? Yeah, that's a great question. And unfortunately, there's not a lot of really hopeful solutions right now. NMC's podiatry situation is pretty tight in terms of availability. My understanding is that in the fall, a new PA is starting in the orthopedic department, and she's going to be available to specifically work with this population of people. And that's not starting till the fall. And even when she does start, there's going to be a lot of training involved. So I don't know when she's actually going to be up and running. So know that it's coming. But until then, you're right. I think that those skilled services are no longer being covered for nurses to provide through home health. And so I think we've been told that there are people providing foot clinics in various areas, right?
Yeah, I
Um,
don't know exactly where though.
Like foot and nail clinics.
I think the Medical Reserve Corps is
Right.
doing one.
Yeah, the Medical Reserve Corps. And we can try to find out more about where that's happening and how frequently. But that's and I think there's stuff like that down in the Chittenden County area too. And then certainly if there's people who just need to be seen and shouldn't wait, um, we just have to try to look to podiatrists in the outlying areas. I know we've sent people to the Copley area, certainly UVM, but I think there's been some providers at UVM who are also saying that they're full, so that's not always successful. It's worth a try because they're the closest, but that's not always successful. And then I think it's also just good to remember, and not everybody knows this, so it's worth just putting the plug in, which is that Plattsburgh does have an outpatient wound center. And so sometimes when people are just not getting their needs met here in the Franklin County area for whatever reason that may be, and getting over to Plattsburgh is a possibility. Even if it's just for one visit, doesn't mean they have to commit to just going to Plattsburgh all the time. But even if they can just get seen one time, that can be really helpful in their trajectory of care, because they are set up with all of the things. So they have access to vascular testing. They have, I think they might have hyperbaric oxygen therapy available, and then they have providers who are trained and skilled in wound care at the provider level, along with nursing staff, and have all the latest dressings and knowledge around wound healing. And so that can be a nice kind of backup if someone really needs to be seen and we're just not able to get them seen, if they can get over there. And I don't even think that last I worked with them, you didn't even need a referral. They could just call and schedule their own appointment. It might move faster when they have a referral, though. If it's coming from a provider, I might be able to get in quicker. Yeah. Okay.
Okay, go ahead.
Yeah, you sort of addressed a little bit. I just was wondering if you had suggestions on, so we see a lot of patients coming in for nail care, can't get into podiatry for months or at all. And it is like, it's kind of a preventive situation. We can either take care of it or it's going to be a wound at some point soon. Kind of, like you can see the trajectory of where the nails are going, digging into the skin, causing pain. The patients are uncomfortable. So I'm just wondering what your suggestions are at like a primary care level, what interventions are helpful? Because referrals aren't
Okay, and this is
working great.
specifically around nail
Nails.
discomfort.
Yeah.
That's a great question. I think, start with the basics. Start with looking at I wouldn't even ask about footwear. I would actually just look at the footwear yourself. So start with what are they wearing on their feet? And how is that landing in connection to how their foot lands? Because a lot of times changes in footwear can make all the difference. And so I think the best thing is to put your own eyes on the footwear and see what their foot looks like in the shoe, and kind of touch where the toes are and where the feet land on the sides. And, if the toes are squished, if there's rubbing happening, if the nail is kind of digging into a toe or anything like that, because that sometimes just a simple change in what they're wearing on their feet can make all the difference. Same thing with like socks. Are they wearing socks that are too thick for their shoe or whatever it is? Just so start there. And then if there's like deformities, or if there's ways that the toes are kind of like pressing up against each other, and that's kind of where the nail discomfort is coming in. Sometimes just something simple like putting gauze in between the toes can be helpful. Or cutting like a thin non-bordered foam that can kind of go in between the toes and stay there to provide a little padding, can be helpful. And yeah, just making sure that the nails themselves are staying trimmed if possible.
One of the
But just
challenges is
think
like
about
thickening
the
nails.
forces that would increase the likeliness of this turning into ulcer development. So the forces being moisture, which will happen if there's sweat building up in between the toes, forces of friction, which will happen if there's too much rubbing within a shoe, or forces of pressure. Pressure can happen not just from the bed, like on a heel, but pressure from a shoe. Stuff like that. So looking at trying to eliminate any of those forces to kind of progress it in the wrong direction. I hope that's
Right.
helpful.
Yeah. Yeah, that's super helpful. One of the challenges is thickening nails. And
Any other questions? I just saw Debbie's comment, so that's helpful, Debbie. She said NMC is planning on having her trained to do some nail care. Be trained, so that's great. So maybe we'll be able to offer some nail care at NMC soon. Thanks, Debbie. Anything else? Okay. Well, people can certainly not hesitate to reach out to me through email. I think my email address was provided, but if you don't have it, we can get that to you. And I can see people in the primary care setting if needed or help answer questions. The other service that I'm available for through this blueprint position is just a consult. So that can be done over the phone, or sometimes I get emails. People can email me photos. That's fine. Anything that's helpful, we're happy to do. Thank you.